What is one of the most unusual cases you've ever seen?
So the clinical case, I think probably the most was this guy. He was working. He amputated his arm, which was essentially above the elbow.
He did that himself?
Well, I know he was a truckie. Some metal part that came down and basically...
Welcome to the Consult by Australian Specialist Hub, where the law meets medicine, and we're speaking to some of our experts today. Dr Mark Nabarro joins me this morning, one of our orthopaedic hand experts. Thank you so much for joining us.
Thank you for having me.
Tell us about your journey. What drew you to medicine and how did you find your way into your specialty?
So probably going back to high school, did a first aid course, and I thought this was really interesting and sort of got me interested in medicine. And went to university, medicine, finished that, and halfway through training I thought that orthopaedics this is what I want to do. I enjoyed the hands-on stuff. Patients are usually well, get good functional recovery, and then looked at how am I going to do that. And so finished my training in Johannesburg, went to UK for a couple of years doing orthopaedics, came to Australia, and then had to get into training here, which proved to be probably a bit harder than expected. But it was what I wanted to do. Got into a training scheme here, did orthopaedics, and during the training you do all different things. You'll do hips and knees, shoulders, spine, and I did a term at the hand unit in Macquarie Street, and I thought this is what I want to do. And it was kind of sliding doors moments. A mentor that I had down at St George knew someone in America, said, would you like to do a hand fellowship there? And so I spent a year in Indianapolis at the Indiana Hand Center doing hands. And kind of the rest is history.
Was there some major differences between the US system and the Australian system?
I found the biggest difference was... The insurance companies there made it really difficult. They said you can go to this hospital, you can see this doctor, and then when you finish, you can go to this hand therapist. It was quite difficult to navigate. The hospital had a whole department just dealing with insurance companies.
Wow, a lot of administration.
Very much so, yeah.
What does a typical month look like for you working with Australian Specialist Hub and your private practice?
So I've just sort of, in the last probably 6 months, started doing medico-legal work. And so just trying to integrate that with private practice. So still seeing patients, clinical patients, operating, and seeing medico-legal stuff in between. So it's been a variety of things, IMEs, some file reviews, a couple of public liability cases. So just... sort of getting into things.
A real mix of things.
Yeah.
And one thing that our team is commonly asked is the difference between what cases go to a plastic and reconstructive surgeon and which would go to an orthopaedic hand surgeon. So did you want to tell me a little bit about that?
I think it depends a lot on what mix of cases they've done. If it's just plastic and reconstructive stuff and then they're doing upper limb, hands, elbow, shoulders, it's probably something that they or may not have treated before. That makes it harder. But certainly, during training, at the hand unit we have plastic surgeons and hand surgeons, orthopaedic surgeons. So if they've done that as part of their fellowship, then I guess that's what they're used to seeing and what they do.
Okay. And what type of cases are you seeing in your private practice, the particular surgeries that you're doing in your day-to-day?
It's a variety of things, so trauma, so fractures, ligament injuries, and then there's the degenerative things, arthritis, carpal tunnel stuff. So it's a whole range.
And that's a mix of sort of motor accidents, or are these more
Sure.
age-related?
Age-related things, motor vehicles, home handyman, the the 7-year-old guy, he gets up on the ladder with a chainsaw to cut his tree, and you know what's going to happen. Yeah, so just a variety of things.
And I'm sure the hand surgeons in Darwin would have been particularly busy over Territory Day. We saw
with the fireworks. I haven't seen one for quite a while. There's one guy that stands out. It's a thing called a Thunder King, which is it's like a tube, and you light one part of it, and that's sort of the first step, and then the second step is this thing shooting out of the tube to a distance and then exploding. And for some reason, it didn't exit the tube, so it blew up in his hands, and he lost 2 fingers on one hand and one on the other, and it was a lot of soft tissue stuff. It was really bad injury.
Oh, wow.
His wife told me they found his wristwatch two houses down.
2 houses down. Wow.
So fireworks are pretty bad for hand injuries. Now, since they've banned them, you can only buy them in Canberra now, or ACT. It's haven't seen many for a while.
There was a case a couple of days in the news where there was a X-ray of a hand that someone had come in for Territory Day, and they said, "Oh, the hand looks absolutely fine," but the only thing, it was no longer attached to the wrist. Yeah.
Drill injuries, angle grinders, they're pretty nasty as well. Chainsaws, because none of these treat hands very kindly. So yeah, we see a lot of tradies. Some minor, but some pretty severe injuries.
Well, what are the chances of when sort of something becomes disconnected that you can reconnect that back on and have success?
It depends where it is and the circumstance, how long it's been, the mechanism of injury. So if it's like an avulsion, traction type injury, that's often much worse than something that's been a clean cut.
Oh, wow.
So the further is, so hands certainly can be replanted, fingers we do frequently. But again, it depends on what's happened and how long it's been and how the part's been treated as well.
Do you see many come in on ice?
Yeah.
Yeah.
And that's the thing. If they come in on ice, oftentimes it's too cold. So it has to be in a plastic bag and then on a slurry of ice and water so it doesn't freeze.
Oh, wow. So the ice can actually cause damage.
The ice can cause damage.
Wow. Where do you see the biggest gaps in how your specialty is currently understood or assessed in the medico-legal system?
I think that a lot of the time people rely on investigations. So MRIs, so that's like straight first thing, MRI. And I think examination, history, and then investigations is the way to go. So I think if you rely on MRIs for things, you're gonna be misled a lot of the time.
Okay. So when our clients are preparing their briefs to send to you for a medico-legal assessment, you're looking for more clinical notes, is there anything in particular that you would say to the clients, this is what you need to include, or this is what I would recommend?
I think just a good history, prior examinations, if they've seen anybody else, other opinions. I think that all helps.
Okay. That's good to know. We're always looking for tips and tricks for our clients so they can improve the referrals. And if you improve the referral, you're always going to get a better.
Yeah, and the questions, so specific questions rather than just to please assess, see if he's okay kind of question. Specific questions and not broad questions, and not questions that ask a question one way and then the next question same way but just a little different, and then third question, so it's almost like it's the same answer for each of them.
We see that a lot. I think a lot of experts find that quite frustrating.
Yeah, the one time I said, I'm just going to put the same answer for each one. can't do that.
What makes your assessments and reports stand apart?
So I think at medical school we were taught history 70%, examination 20%, investigations 10%. And I think you've got to sit and you've got to talk to the patient, get a good history. It's not good enough just to say, where do you work? You need to find out what their work involves, how many hours they're doing, how long they've been doing it for, and then the examination. I think that's important. I see a lot of reports and patients come to me and say, I went for an IME. I said, did he examine your hand? And he said, do this, do that. You saw anywhere? Okay, that's the examination. I just think you need a thorough clinical examination to find out, what's happening. and where you're going to direct your investigations as well.
And we just spoke about your examination room being set up a little bit different to your regular examination room. You've actually got a table.
Yeah, I've got a table with some cushioning on it, so I sit across from the patient so they can examine their hands so they're relaxed. There's some tests you need to do with the elbow stabilised, and so it's very difficult to do it without them resting on something.
And what sort of tools are you using when you're doing your tests?
So I use a goniometer. So you've got a couple on the table there to measure finger range of motion, wrist range of motion. Got a 2-point discriminator to measure sensation in fingers, and then a dynamometer for grip strength.
And what are you looking for with the 2-point discriminator?
So normal 2-point discrimination is about 6 millimeters. So at 6 millimeters apart, you can detect 2 points. As if sensation is altered in carpal tunnel or nerve injury, that becomes greater and greater. So it might come out to 15 millimeters. So it just gives you an indicator of how the nerve is working.
Okay.
More accurate than saying, can you feel that? Can you feel it? It's a more objective test than just touching.
Okay, because I think that's something that's quite new to our audience. A lot of people have seen the pinprick test and sort of people use a tissue on the skin, but not sure how the 2-point.
I just find it's just a more objective way of quantifying sensation.
Okay, that's really important. What is something in your area of medico-legal space that is consistently misunderstood? Something that you would like to set the record straight on?
I think a couple of things. I think, as I said, MRI scan. So if you get an MRI scan of a person who's, say, 50 years old, you will find some abnormality in pretty much everybody. So it might be a little ganglion, might be some arthritis, but you can't just go on what the report says. You need to correlate that with what your clinical findings are. So if they're tender in an area or there's some test that's positive in an area that correlates with the MRI finding, then that's an important thing. So just to rely on an MRI scan, so it shows this. If they're not sensitive there or tender there, then it's not that relevant.
Okay.
So I think correlating your clinical findings with your radiological findings is important.
It's really important. And just be so thorough with your assessments.
Yeah, trying to.
What is one of the most unusual cases you've ever seen?
Unusual case, as in a clinical case or a medico-legal case?
Oh, one of each. I find the clinical cases very, very interesting.
So the clinical case, I think probably the most was this guy who he was working. He amputated his arm. It was essentially above the elbow.
He did that himself?
I know he was a truckie, and it was some metal part that came down and basically amputated his arm. So he came in, they had the arm, it was prepared, it was everything. And he was only in his 30s at the time.
So young.
And so we thought we'll try and put it on. So I had that orthopaedic surgeon help me, and we fixed the bones. And then we started working on the arteries and the tendons and nerves. And he did okay for a while. And then...
How long did that surgery take?
It took a while. It's probably about 6 or 7 hours.
Wow. And
then I can't remember what happened, but basically the venous outflow stopped working. We redid them, but in the end we had to amputate. And I saw him a few years later for something in his other hand, and he was doing pretty well. He was getting on with life. He changed jobs, but he was pretty upbeat sort of guy, which helped. And he came to see him. I think he had carpal tunnel in his opposite hand. But that was early on in my career. It was something that still sticks with me.
A shocking case. Was he using a prosthetic when he came back to you or anything like that?
No.
Do a lot of your patients go on to use prosthetics like for fingers?
Fingers, I found that you can get prosthetic fingers that look, if you look at someone, you wouldn't be able to tell. But from a functional point of view, they don't work because they're insensate. And so often they might put it on when they go out, but when they want to do something, they take it off because it's not functional.
Okay. It's more a cosmetic thing.
Yeah, more a cosmetic thing. But above, the arm patients use prostheses.
Okay.
And some of them are quite amazing what they can do.
Some of the robotic ones we've seen online are just becoming incredible.
Yeah. Last month, I think I've seen two patients. One of them I operated on in 2008, and another one was maybe 10 years ago, and they've come back with a different issue. So it's not uncommon.
I noticed on your profile it says you do hand, wrist, and forearm. Where does that sort of stop as far as clients sending you referrals? Does that include the elbow, or is it sort of just more the wrist injuries?
Good question. So what I do is really hand, wrist. I mean, some forearm fractures. I do ulnar nerve compression at the elbow.
Okay.
But I don't do any elbow surgery per se.
Okay, so if we got an elbow, that would more go to a...
It depends what it is. I mean, I do upper limb stuff, but specific elbow, shoulder surgeries, I don't do.
Okay, that's good to know.
You want to know about the medico-legal case?
Oh, yes. Yes. Absolutely.
I mean, a few, but this one was a lady with cubital tunnel syndrome, which is compression of the ulnar nerve at the elbow. And she had, if you tap on the nerve, they get tingles in the fingers. She had lost sensation. She had a bit of weakness in her hand. And I said, look, I think she needs surgery. And the surgery is to take the nerve and transpose it, so move it forward so it's not being compressed, and just relieve the pressure on the nerve. And I said she needs an anterior transposition of the ulnar nerve, and I thought it would be straightforward, but the insurance company decided to send her for an IME because they like to check that we're doing the right thing. So they sent her for a second opinion to a plastic surgeon, and I hadn't heard of the guy, and I had a look at what he does, and his area of expertise, I think he's retired, was gender reassignment surgery. That's what he'd done during his career. Okay. And got his report back saying he'd examined the patient and he could find no signs of cubital tunnel, and as far as he was concerned, there was nothing wrong with this lady. Okay. So I examined her again, and she definitely had it. And I said to the insurance company, I said, look, I'm happy for you to get a second opinion. I don't have any problem with anybody getting a second opinion. But please, if you're going to send it to somebody who does hand surgery and has probably treated a cubital tunnel syndrome case before. And they said, okay. And they sent it to actually a guy I know well, who was one of my mentors, and he said, look, she's got cubital tunnel syndrome. She needs surgery. And I just think that's important. If you're going to send it to someone who's actually seen the condition and treated it, rather than somebody who hasn't really done that kind of stuff before.
Absolutely, I agree. It should be treated. If you haven't treated it, I don't think you should be going into complex medico-legal work in that area. But there are particular cases where you need someone with that accreditation. There's always an exception, exactly. But I agree with that. So it's a common tradition that we ask a couple of quick-fire questions to our guests on the consult. If you weren't in medicine, what would you be doing?
Good question. So I guess it depends at what stage. So when I was at primary school, fireman. When I was in high school, at one stage thought, don't know, maybe rock star, something like that, and then found didn't have a musical bone in my body, so that was never going to work. And then fell into medicine and haven't looked back.
Dr. Nabarro, what do you do to switch off?
Like a relaxing game of golf, as they say. And I think it's going to be relaxing, and halfway through the round, it's maybe more tense than before.
Becoming a little bit less relaxing.
Yeah.
What is your favourite part of your job?
I think it's talking to patients, listening to them, and coming up with a diagnosis, and then hopefully implementing a treatment plan and seeing them respond to that.
It changes people's livelihood. It's so important.
Yeah.
Oh, do you have a favourite case?
I enjoy trauma, so I'm fixing fractures. I think they're usually very satisfying. It's like you've got a jigsaw puzzle and you've got to put it back together again and hold it with plates and screws, and it's pretty satisfying when you do that, and then the patient recovers function afterwards. It's good.
And I've heard it's one of the hardest areas to do an impairment assessment on as well.
Fractures.
Fingers.
think it's, I think all parts are hard to do an impairment assessment.
In the hand?
Yeah.
Yeah.
But fingers, yeah, you've got a lot of moving parts. Things
There's
to
a lot
assess.
going on. Well, thank you, Dr. Nabarro, for joining us on the consult today. It's been a pleasure.
Thank you. Thank you for having me.